all those funny words that I talked about on the diagnosis and talking about the WHO criteria, what they are, you're going to see their pictures here. Okay? So luckily I don't have to do much talking. It's mostly just you up here looking at the pictures. This is what a lot of the things look like. Okay? So we're going to look at the clinical features of HIV. What are the staging systems? What are some of these funny, what is papular pruritic eruption? What is molluscum contagiosum? Well, you're going to see pictures of all these funny skin rashes, all these strange things during this lecture. Okay? Remember that you can initiate ARVs based on clinical data. You see somebody with one of these things, if it's stage 3, if it's stage 4, a child will qualify. If it's stage 4, any adult will qualify. It does not matter about the CD4. You don't always need a CD4. It can take you weeks sometimes to get the result of a CD4 back. It takes you 5 seconds to do a physical exam. So you might know that they qualify for ARVs right there just by putting your hands on a person. Okay? Just by looking at them. Just by looking up their lab results. Just by asking them a few questions. You might know that they qualify for ARVs. You don't have to wait 2, 4, 6 weeks before they get their CD4 count back. Okay? So just a bit of a review, very, very brief. HIV is a virus. We all know that. It attacks the immune system. You become sick when the immune system gets weak. Okay? You no longer are protected from infections. Those infections make you sick. That's how HIV works. Okay? So HIV individuals, as their CD4 count drops, they get infections with things that the normal immune system would wipe out. It would take care of it. It would kill it. You'd be fine. You wouldn't notice a thing. But when your CD4 drops, you get sick with those things. Your body can't fight them off anymore. Okay? And you get things like opportunistic infections. But you can get other things. Things that you would normally get that, okay, it takes a while for your immune system to fight off, like diarrhea. But in a person who's HIV positive, that diarrhea is worse. It lasts longer. HIV negative people get pneumonias. But somebody who's HIV positive, it can be a worse pneumonia. It can take them longer to recover because their CD4 is low. Okay? So why do you need to know about the clinical manifestations? It's because initiation of treatment also depends on clinical status. That's obviously the theme of today, right? As well as immunologic status. It's not just the CD4. Also clinically, we can start treatment based on some of these things. Okay? So I'll just skip that. Okay? So if we know the WHO stage, if we recognize what some of these things are and what stage they are, we can stage them. We can know whether they need treatment or whether they don't need treatment. Okay? You saw this graph earlier today. There's immunologic staging. There's clinical staging. You know the stage is based on CD4s. We all have put to our memories. We all can look up quickly who qualifies, who doesn't. But it's harder to remember the WHO staging. Remember that there's long periods of time where you might be fine before you get sick, the clinical latency. And then you get constitutional symptoms. Look, where does this actually happen? If you look down here, CD4 count of about 300. These are where some of the things start to come out. You'll start to get the stage 2 things. Skin rashes. Okay? Big liver, big spleen, parotid enlargement. Your blood counts might drop. So you can start to become stage 2, stage 3, stage 4. Adults generally progress along that way. Children are different. Children don't follow that path very nicely. This is a graph for adults, not for children. Okay, they don't always come out stage 2, stage 3, stage 4. A child less than a year can get PCP pneumonia. That could be the first thing they get. And then they die. So they won't go stage 2, stage 3, stage 4. So it's important to know the progression and to be able to see where somebody is. In an adult, they typically follow this pattern. This is the reason why we do a lot of what we do in HIV. As your CD4 declines, you're at risk of developing other types of infections, different types of infections. As your CD4 count is below 400, your risk of developing shingles is higher. TB, well, anybody can get TB, HIV negative, HIV positive. But most HIV negative people who get TB, they don't get very sick from it. But HIV positive people, they get very sick from it and can die from it. So the number one cause of death in adults with HIV is TB. At a CD4 count below 350, they start to get severe TB. And TB not just in the lungs, can spread throughout the body. They can get TB meningitis, TB of the abdomen, TB of the heart, TB of the joints, can be TB anywhere. As you'll learn about in the TB lecture, I say TB can cause everything except pregnancy. Okay? And sometimes I get worried that it may do that someday. Okay. As your CD4 drops even lower, to 300, you can start to get other things, oral thrush. And as it gets below 200, this is where the very severe things start to come out. PCP pneumonia, esophageal candidiasis, herpes lesions. These things start to become more and more serious, more and more life-threatening. So why do we pick 200? Why is it that 200 is where we start? Why should it be 200? Why not 350? Why not 400? What's at 200 where your risk of getting these opportunistic infections skyrockets? Once you get below 200, your risk of developing these opportunistic infections gets higher and higher and higher. That's why we've picked 200. Okay? That's why 200 is where you're no longer HIV positive, you're now considered AIDS. Because your risk of developing these infections is higher and higher and higher. And as your CD4 drops lower, there's more and more and more things you can get sick with. Toxoplasmosis, Cryptococcus, MAC, CMV. And as it gets lower and lower and lower, there's more and more things that you can get sick with. Okay? So now we're going to go through stage by stage and show you what they look like. Well, stage 1 looks like this, looks like me, looks like anybody. Perfectly normal, perfectly healthy. They may have persistent generalized lymphadenopathy or swollen glands. So you don't often see it, but if you feel in the neck, you feel lots of glands, you feel up here, there's glands, you feel under the armpits, there's glands, you feel in the groin, there's glands. Very common in children. Very, very common. That's still stage 1. That's still only stage 1. Okay? Otherwise, that's it. Those are the only things. Either you're perfectly fine, you may have some swollen glands, otherwise you're healthy. Okay, so this would be a picture of a girl who's stage 1. She looks perfectly fine, right? Perfectly healthy. Okay. So what about stage 2? Now, as I said, stage 2 is where things start to come out. All of the things at stage 2 you can diagnose by looking at somebody, by putting your hands on them. You don't need fancy lab tests. You don't need anything sophisticated. You can diagnose somebody as stage 2 simply by doing a clinical exam. Okay? They're starting to get sick. They're starting to lose weight. CD4 is dropping. Viral load is getting higher. So this is papular pruritic eruption. Now, it's a funny word, a bunch of funny words together. But if you hear them all together and know what each one means, it describes this rash exactly. Papular is a fancy word for bump. It's just bumps. Pruritic is a fancy word for itchy. Eruption is a long word that means it's everywhere. So it's an itchy, bumpy rash that's everywhere. That's papular pruritic eruption.
But sometimes you can have some of these infections even if they're not HIV.
Yeah, absolutely, absolutely. So some of these things you can have. These things do not mean that you're absolutely HIV positive. You can have many of these things and still be HIV negative. But if you're HIV positive and have these things, that puts you into this stage. Now you can see this gentleman. It's not always as extensive as this. This is a pretty extensive case. But it usually involves the upper back and lower back, the chest, can be on the arms and hands here, and this is a part of the upper back. It's bumpy rash, and it's usually very, very, very itchy. Particularly kids, you see scratching. Remember the child in the video? We all saw him scratching his legs. It was papular pruritic eruption. Okay, that's why. It could have been scabies too. Yeah, this looks a lot like scabies. This could be scabies as well. Scabies will have tunnels and things linking together, and sometimes you get more pustules with scabies, which you won't see with this. It's very difficult to differentiate the papular pruritic eruption from something called eosinophilic folliculitis. They're very similar. The treatment is very similar. They're just two different entities. The big difference between this one and the other one, this looks a bit more like acne, and it's more on the upper body, face and upper neck. Okay, whereas the other is more sort of everywhere. Okay. This is usually with very, very, very low CD4 counts. I know it's only stage 2 in and of itself, but usually it happens with a CD4 count less than 100. This, more than the other one, is even more itchy than the other one. This usually drives people crazy because they're always itching. You can try topical steroids and antihistamines to help with the itching, but really for both of these things, no matter what you prescribe, it's not going to cure it. The only thing that will make it go away is ARVs. Unfortunately, it's stage 2, so if this is all they have, they don't qualify. And if their CD4 is high, they wouldn't qualify in 7. It is not contagious, neither of them. They're not in infection. This is a severe case of molluscum contagiosum. Okay. It's very common in children, often not this severe, but this shows you an extreme case of where you commonly see it. It commonly is above on the eyebrows and forehead. There are these very smooth, round dots with, you can see it in the enlarged one, there's usually a dot in the center, a bit of a crater in some of them. Looks sort of like a volcano. It's nice and smooth, and it's collapsed in the middle. It can be very severe. If it goes along an eye or an organ, this child actually ended up being blind in this eye. This is contagious. Not typically to other people, but say he scratches here, it can spread along there. That's typically why it clusters in certain areas. If he rubs this eye and nose, you see it mostly clusters on this side of the face. If he's going like this, it spreads it. Okay. The treatment for this is ARVs. This one, much more than the other two, usually goes away. I've seen cases not as extensive as that eye, but throughout the whole body, all over the place, very disfiguring. Within 1 year of treatment, I could not find one dot on the child. Completely went away with ARVs. Completely. Okay. So oftentimes on ARVs, they get better. It usually goes completely away on ARVs. Okay. In extensive cases like this, they may need local surgery as well to remove some of the lesions. This one, what is this? I'm losing my voice, so you guys do the talking now. What is this? Yeah. So there's actually two things in this picture. There's a fingernail infection and also infection around the nail. That's called paronychia. When the around the nail is also infected, it's very, very, very painful. Unlike when the fingernail is just infected, that's not painful at all. But the infection around it, where it gets red and swollen, very painful, it's called paronychia. Okay, that will respond to antibiotics. But this is all of these things are still only stage 2. What is this one? See this here? What is this? It's herpes, yes. This is a herpes lesion, herpes simplex virus of the lips, referred to as herpes labialis. How do you treat this? How do you treat this? Acyclovir. Acyclovir is the treatment. Now, it can be on the lips. Herpes can be anywhere. And it doesn't always cause the same thing. You see this tongue. It's causing a very large ulcer on the tongue. You see it's eroded here. Also, the lips here can also be in the genital area. Okay, so you can get stomatitis of the tongue, labialis, as we saw in the other one, angular cheilitis, and also in the genitals. Okay. The same virus that can cause, or similar family of virus, a herpes virus, can cause herpes zoster or shingles. Okay. Shingles is different than the other rashes because it's only on one side of the body. It never crosses the middle. So it would only be on one side. It would never go to the other side. And that's how it's easy to tell shingles from another kind of rash. It's a blister. It contains fluid, okay, inside, and it's very painful, very itchy, very uncomfortable. This one, I have a few pictures of this because this is very, 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 very common in children. Okay, it's called verruca planus. Again, this is another fancy word. If you know what it means, it describes it exactly. Verruca, fancy word for wart. Planus, fancy word for flat. It's a flat wart. Common in children, and this is a good picture because it shows you where it's commonly distributed. Commonly along the hairline and along the back of the neck. You can see these linear formations as well. This is still stage 2. What is the treatment for this one? There's no treatment for this one. Will it go away with ARVs? Most of the time, no. No. So this is another picture. You can see it can cluster usually along the hairline behind the ear. This is very, very, very difficult to treat. It often does not go away with ARVs. ARVs will stop it from progressing. It usually doesn't get worse on ARVs, but I've had children on ARVs for years, and it does not go away. So I would not encourage them. A lot of people give them aqueous cream, give them steroids, give them this, that, the other thing. It's all a waste of time. It's all a waste of money. The only thing that will help it is ARVs, and even that does not help it most of the time. You can see it also can occur on the neck of this child here. So that's verruca planus, which is flat warts. The HPV virus, which causes the common wart. As you know, regular people get warts as well, but usually HIV-infected people get severe warts, and they can be very disfiguring. They can spread rapidly and be very, very disfiguring. So 1 or 2 warts is very, very normal, but if it's extensive, it's all over the place, you would consider HIV. Again, this is some pretty extensive on the hands and fingernails here. The same virus, not just the hands, it can be anywhere, commonly in the genital area. You can see this is the anus, and those are usually called condyloma accumulata. They're usually asymptomatic. They don't itch very much. They don't really cause much of a problem. In the genital area, it can cause some mild itching, bleeding, burning, tenderness, even discharge. The local treatment is the best. Podophyllin. Extensive ones can require surgery, and they can be very extensive. I've had a few children where they've had anal warts so severe it has actually closed their anus. They've had to have an operation and even an ostomy because their anus didn't work anymore because of this. The same can be true about the genitals. Okay. This is called linear gingival erythema. Again, it's a bunch of fancy words. If you break it down, you know exactly what it is. Linear just means a line. Gingival means the gums. Erythema means red. So these red lines right above the teeth here. This is very painful. It bleeds very easily. Simply brushing your teeth, even eating, can cause them to bleed, and it's very, very painful. Patients with this often do not want to eat because it even hurts to chew. Okay? Remember, this is still only stage 2. Seborrheic dermatitis, dry skin. It's dry skin or eczema, same thing, seborrheic dermatitis. Dry, scaly rash. In HIV-positive patients, it can be difficult to treat. Topical steroids can be helpful. Aqueous cream can be helpful. Avoid using soaps with perfume. Avoid using hot water. Avoid multiple baths. A lot of times in children, a child with bad seborrheic dermatitis, the family will give the child 2, 3, 4 baths a day to try to scrub it off. That actually just makes it worse. So less baths. You don't want to rub and irritate the skin more. Less baths, less rubbing is better. Parotid enlargement doesn't show up very, very well, but you can see a little bit of a bump out in the cheek, and that's parotid enlargement. Stage 2, very common in children if you look for it. They'll have these kind of big, puffy, chipmunk-looking cheeks. And that's, again, still all this is stage 2. Chronic serous otitis media or chronic suppurative otitis media. These are more common in children with discharging ears. This means they've had chronic ear infections, their eardrum is ruptured, and the infection is draining out. Okay, so you'll commonly see discharging ears. This is a very, very bad problem in children because it can lead to hearing loss. They can actually become deaf or partially deaf from chronic ear infections and chronically ruptured tympanic membrane. So this should be addressed early. Unfortunately, it's still only stage 2, although it can be very severe and even lead to deafness. What will help this? There are topical things you can use. Sulfurdex is a common antibiotic with steroid you can use. Many clinics can't get that, so you can use acetic acid with wicking, but ARVs are important to really help decrease the number of infections they get and to help this problem. So these patients are all getting sick. Adults and children, they're starting to get sick. But in South Africa, as of right now, they do not qualify for ARVs on clinical grounds only. They may qualify if their CD4 is low, but if their CD4 is high, and this is all they have, they still don't qualify. Okay. So stage 3. So in summary, as I told you before, stage 2, skin rashes, things you can see with your eyes, feel with your hands. Stage 3, I say they're getting pretty sick. This is starting to be pretty darn sick in my eyes. Stage 3. And remember stage 3, pulmonary TB, it rhymes. That's another one. So we'll go through some of the moderate malnutrition. We talked about in the nutrition lecture. Persistent diarrhea, fevers, thrush, oral hairy leukoplakia, pulmonary TB. I want you all to remember that one. Okay. So if you see a child with any of these things, they do qualify for ARVs based on exam, based on these findings only. Adults wouldn't yet qualify. So unfortunately in South Africa, adults don't qualify at stage 3. This means a child with a CD4 count can be 2,500, 45%. It does not matter. If they have one of these things, if they have pulmonary TB, they qualify for ARVs. If they have persistent diarrhea, if they have malnutrition, it does not matter what their CD4 count is. They still qualify for ARVs. Okay. So this is thrush. And this is commonly how you would see thrush. A lot of people think thrush is mostly only on the tongue, but it's usually not. It's usually throughout the mouth, on the sides of the cheeks and on the roof of the mouth. And so this is thrush. Treated with either topicals, antifungus, or fluconazole tablets if it's severe. This is oral hairy leukoplakia. Again, if you break down the words and know what they mean, it describes it exactly. Oral means mouth. Hairy, because if you look at it very closely, it looks like little hairs sticking out from the sides. Leuko means white. It's white. And plakia means it's stuck on. So it looks like somebody stuck these little white hairs on the sides of the tongue. And it's very common on the sides of the tongue like this, or on the top upper part of the tongue. I think this is my only picture of it. Yeah. So, but this is the common part, on the sides of the tongue or on the top along the sides. And if you shine a light on it from the side, it looks like little hairs sticking up. And so it's usually asymptomatic. Patients don't know they have it unless they say, yeah, my tongue's a funny color. But it doesn't itch, it doesn't hurt. Patients usually don't even know about it. Okay. There's really no treatment other than ARVs. Pulmonary TB. You've got to remember this. Pulmonary TB, stage 3, all children qualify for ARVs. All children. The new guidelines, adults qualify if their CD4 is less than 350. So how do you diagnose TB? Can you do it right on the spot? Can I find a child comes to me that day and I say, you're not leaving this place without TB treatment? Or do I need sputum? What do you think? Do I need sputum? There's an injection you could use, right? You could use sputum. But you can also diagnose it clinically without any exam, without any equipment, without any x-ray, without any sputum. And we're going to talk about exactly how to do that during the TB lecture. But these are the common symptoms. Chronic cough over 2 weeks. Productive sputum. Weight loss, night sweats, fatigue, fever. Okay, to confirm a diagnosis, you can get sputum for x-ray. You can diagnose it with sputum for AFB. You can get an x-ray or you can diagnose it clinically. So there was a child I saw yesterday, in clinic at Don McKenzie. She was 12 years old. She weighed 20 kilos. She was way, way, way down on that graph, less than 5%. Very underweight. She's been coughing for 2 months. She's been to the doctor, got several courses of antibiotics, hasn't worked. She's been losing weight. She's not eating. She's sweating at night so that when she wakes up in the morning, her clothes are wet. She has to change her clothes in the morning. Sometimes in the middle of the night, she has to get out of bed to change her clothes because they're soaking wet. She's been having fevers. Do I need an x-ray for this child? This child has TB. There's nothing else that's going to do it. There's nothing else I'm going to do this. Should I get sputum, wait 4 days before I get results? Maybe the results aren't come back. Maybe she can't produce sputum. She has TB. You can diagnose it clinically. She hit every single one of these. Chronic cough, sputum, she's losing weight, she's malnourished, she's underweight, she's sweating, fatigue, she's having fever. You can clinically diagnose TB. To make it even stronger, her uncle who lives in her house just died of TB. So there's a contact. Okay? So you know that this child has TB. Okay? Something that's very difficult to differentiate from TB. Now this is probably the first time everybody in this room is going to hear this word, but it's not going to be the last. It's called lymphoid interstitial pneumonitis. It occurs almost always only in children. Very rare for an adult to get this. Very rare. It looks exactly like TB. They present exactly like TB. The physical signs are exactly like TB. The x-ray is exactly like TB. But how is it different? Well, their sputum will be negative. It does not respond to TB treatment. And there are a few things that can differentiate. They often have this thing called clubbing. You see at the fingers here. These are very widened. They're even a bit blue colored. Now, the best way to diagnose clubbing is if you take your fingers and you put them together. You take your middle finger, you put them together, tip, and your first knuckle on the tip. You should see a little diamond in there. People who have clubbing, that diamond space, little diamond space, if you all do it, you should look and you should see a nice little diamond shape between your fingers. Well, as the tip gets flattened and widened, you lose that diamond shape. And that's what clubbing is. Very common in children with chronic lung disease and LIP. You don't often see it in TB. You can if patients have had repeated TB infections, but it's much more common in LIP. So usually they otherwise look pretty healthy, but they often have chronic symptoms. They've been coughing how long? A year, 6 months, 2 years. It's recurrent cough. They're usually breathing fast, faster than normal. They often have parotid enlargement in children, these big puffy cheeks. They often have a big liver and spleen if you feel their belly. If you listen to their chest, you'll hear every sound imaginable. They will be wheezing, there'll be rhonchi, there'll be crackles, there'll be squeaks and squeals and all these weird different sounds. Okay? They may have clubbing. Okay? It does not respond to TB treatment. They may have had several courses of TB treatment without positive sputum. Now, the worst case of LIP I've seen was a child originally at Don McKenzie Hospital when I got there. She had been on TB treatment. What's the normal course for TB? 6 months. She hadn't been on for 6 months. She hadn't been on for 12 months. She had been on for 18 months of TB treatment. I asked her, have you been any different from the very first day you started up till now? She says, no, I'm not any better. You cough every single day I cough. You cough at night. It keeps me awake at night because I'm coughing so much. She had 22 negative sputums for TB. 22. She had 8 x-rays over these 18 months. All the same. Not getting better, really not getting much worse. 8 x-rays, 22 sputums. Not getting better on the same treatment. Well, it doesn't take rocket science to figure out what you're doing is not working. At the time, she was not even tested for HIV. We tested her, she was positive, we got her on ARVs, and she got better. Not completely. By the time it's that late and that long on treatment, you're not going to be back to normal, but you can improve her function. So, the best way to diagnose LIP, it looks like TB, it sounds like TB, X-ray looks like TB. So what do you do? Well, the only way I can tell somebody you have LIP is if I treat them for TB first. I treat them for TB first. They haven't gotten any better. They never had positive sputum to begin with. Well, after their full course of TB treatment, then I say, well, it's probably LIP. This is stage 3. So a child would qualify for ARVs because of this. Diarrhea can be stage 3. Now, everybody gets diarrhea. So what's the difference between HIV-related diarrhea and just regular diarrhea? Well, HIV-associated diarrhea usually lasts a long time. Over 2 weeks, can be up to over 30 days, can be months at a time. There's usually weight loss involved. There's usually not any fever. In just non-HIV-associated diarrhea is usually a very short course, less than a week, usually 3 to 5 days. Much more commonly has vomiting involved, and also much more commonly has fever involved. So these are short, brief, intense episodes of diarrhea where HIV-associated is sort of chronic, long-term, weight loss, no fever related diarrhea. And then malnutrition. Now there's several different forms of malnutrition. One is just protein energy malnutrition, like this child, very skinny, bones sticking out, ribs sticking out, child who's very, very malnourished. Well, how do I say what's moderate, what's severe? Well, you're comparing acute with chronic malnutrition. And the best way to do it is to put them on the graph. And what do they look like on those graphs? So you compare their height and weight, and a child who looks thin or even wasted, that's chronic malnutrition. Acute malnutrition is something like kwashiorkor, where they might actually even appear fat. They might have swollen legs and a big fat belly. Okay, that's more protein malnutrition. That's usually more acute in the short term. Okay. Children with normal, have normal weight, but their height is very, very, very low. You'll see this in most HIV-positive children. Even by the time they're on ARVs, their weight becomes normal. If you plot their height, it's way, way, way below where it should be. Okay, so chronic stunting is something we see very commonly in HIV. So the best way to diagnose it is to use what we call the Z-scores. And this is age, weight for length, and weight for age Z-scores. You simply take the child's weight for age, and then you plot them on the graph. Okay? So anything in the red would be very severe malnutrition, and the orange is malnutrition. 1 is normal. Anything in this area is normal. So you take their height, you take their weight, whatever it is, you can plot them on this. If there are more than 2 standard deviations, that's the SD, that's severe malnutrition. That's a medical emergency. They should be usually hospitalized for that. So a child at 63 centimeters should be at about 6.6 kilos. If they're less than that, if they're 5.5 or even worse, 5.1 kilos, then that's severe malnutrition. And that's how you use that little graph. Remember, there are lab criteria which can qualify you for ARVs. Okay, that's not a CD4 count. Most of them are involved in the FBC. So if you're anemic with a hemoglobin less than 8, if you're thrombocytopenia, which means low platelets, less than 50, or neutropenia, your activated neutrophil count is less than 500. That's something you have to calculate, which is your white blood cells times your neutrophil percentage. If that number is less than 500, all of these things qualify a child for ARVs. Okay. So those are people who are getting sick. All of those children qualify for ARVs. And now we'll talk about stage 4. Stage 4 illnesses are all life-threatening. Without treatment, they will kill you. Okay, the patient will die without treatment. Without ARVs, soon the patients will die. Okay. Finally, adults will qualify with any of these things on ARVs. Most of these things are considered opportunistic infections. So we're going to talk about them next time we meet during that lecture. But in this lecture, I'm going to talk about the things that are stage 4, where somebody may actually walk into a clinic with. Because almost every other thing up there requires hospitalization. These patients are very, very sick, and they're dying. But there are a few things that are stage 4 where a patient may present to a clinic or to an OPD or to an emergency department with these things. And those are the ones that I'm going to talk about today. The other opportunistic infections we're going to talk about next time. So that's what I'm telling you there. So these patients are really sick. They're very sick and they're dying. Anybody with these things qualifies for ARVs, and they need them urgently. The new guidelines say people who are stage 4 should start within 2 weeks, regardless of CD4 count. Okay? So these patients need to start quickly onto ARVs. So one that you may see walking into clinic and looking otherwise well is Kaposi's sarcoma. It's a type of cancer that involves the blood vessels. It's a purplish lesion. It's always raised. Okay? It's usually on the extremities, like arms and legs, but it can be inside the mouth. It can be also on the inside of the body in places you can't see. It can be in the lungs or in the GI tract. And that can be where it's very, very, very severe. On a white person, you can appreciate the purple color much, much, much more easy. On black individuals or darker skinned, it's harder to tell that purple color. And so this is a child with pretty severe Kaposi's sarcoma. Looking at it on a slide like this from where you're sitting, it would be hard for me to say this is Kaposi's sarcoma. This could be papular pruritic eruption. These could be scars from old folliculitis. These could be hyperpigmented scars from old mosquito bites, infections like that. Particularly on these legs, it's hard to tell. The best way to tell is a biopsy. And we can't always do a biopsy. A very simple test that I do, hyperpigmented scars from folliculitis, from bug bites, from old skin infections, they're flat. Kaposi sarcoma is elevated. It's a bump. So simply take your hand and run it down his leg. If you feel a bump, I would be more worried about Kaposi sarcoma. They often get big lymph nodes in the area. So the groin, if there's lots of lesions on the legs, the lymph nodes in the groin are often enlarged. Okay? Somebody like that would need a biopsy to diagnose Kaposi sarcoma. It can be located in the mouth, usually right in this spot, the upper part of the top roof of the mouth. If it's in the roof of the mouth, it's usually also, for some reason, in the lungs. So this becomes very, very severe. Okay? Because if it's in the mouth, it can be also in the lungs. So this can be very, very, very severe. Remember, these are blood vessels. So if it's in the lungs, they might be coughing up blood. If it grows bigger, 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 it can even obstruct the airway. So it can be very, very, very severe. Okay? So they're most often on the skin, but it can be really anywhere. They may be flat, but they're usually raised. You almost always feel them, and they're nodules. They have this purple-brown color. It can cause big problems, and it's mostly from blockages. It can block the lymph nodes in the legs, and you can get a big swollen leg. It can cause obstruction in the abdomen, so lots of vomiting and not passing stool. And it can cause coughing up blood if it's in the lungs. PCP pneumonia. When will you see this presenting to the clinic? Well, it will be a child. When a child presents with PCP pneumonia, they are very, very, very sick. Usually breathing very fast, and it looks like a very, very, very bad pneumonia. You cannot tell the difference from a bacterial pneumonia just by x-ray or just by exam. But these children would not respond to traditional regular antibiotics. They need high-dose cotrimoxazole. Okay. So it's similar to other types of pneumonia. They're almost always breathing fast, coughing, and having shortness of breath. The lung sounds might even be normal. It doesn't sound as bad as something like LIP or TB. If you have a chance to check their oxygen levels, they're generally very, very low, less than 90%. And they don't respond to standard antibiotics because it's not a standard infection. Patients often complain of headaches. It's a very common sign in any clinic. If it's HIV clinic or a diabetic clinic or a high blood pressure clinic, headaches are very common. So what is a dangerous headache and what's just a regular headache? Well, it can be hard to tell the difference. There are certain things, like these serious things, that can cause headaches, like a brain lesion, like toxoplasmosis or CNS lymphoma. Can be meningitis, caused from TB, caused from bacteria, caused from Cryptococcus, caused from viruses. This is a picture of, you often see CT scans, but this is what toxoplasmosis looks like on a CT scan. It's a fungal infection that's growing inside the brain. So the headache it produces will be very, very different than just a regular standard headache. This is something that's been there for a while. It continues to grow and get worse and worse. So it won't be a headache that you get when you're stressed out and you take Panado and it goes away. It won't be a headache you get because your children are screaming, you're having to make dinner, and you get a headache, you take some Brufen and it goes away. These are severe headaches. Usually causes vomiting, can cause vision changes, blurred vision, can wake you up in the middle of the night from your sleep with a headache. Those are all warning signs of very, very, very bad headaches. As it grows bigger and bigger, it can cause worse symptoms, like seizures, hemiparesis, meaning looking like a stroke, cranial nerve palsies, severe localized headache, changes in cognition, personality changes, Often, because the pressure in the brain is getting high, people say, like, if I bend over to tie my shoes, I bend over like that, I feel the pressure in my head. It gets worse and worse and worse. Now, that's a severe headache. That requires investigation. Okay. Cryptococcal meningitis also is a headache, but it usually lasts a long time. It's more slow than something like toxoplasmosis. It can be a headache that lasts for a long time, weeks, months. It's usually gradual onset. There can be fever, headache, altered mental status. Often causes vision problems because the pressure in the brain gets very, very high. So they can have double vision, they can have blurry vision. So that's a tip-off that there's something there. To diagnose it, you need to do a lumbar puncture. But there are other types of headaches. Migraine headaches can do most of those other things too, and they can look like that. But they're usually short. They can last long for types of headaches, 2 to 3 hours, but they don't last 3 days, 5 days, 7 days, a week. Migraine headaches don't typically wake you up from your sleep. You're sleeping peacefully and you wake up because your head hurts. That's not normal. Severe headaches in the early morning, it's a warning sign. Probably not the same thing. But migraine headaches can give you visual symptoms. Some people see spots before their eyes before the headache comes on. Blurry vision before the headache comes on. Dancing lights before the headache comes on. And then the headache comes on and it lasts for a few hours. Okay. Tension headaches usually are at the temples, the sides. Feels like somebody's squeezing the headache. These will respond to brufen, will respond to Panado. Cluster headaches, stress-related headaches, sinus headaches, usually will respond to treatment, whereas these other things, brufen, Panado, will not help. Esophageal candidiasis. Well, oral thrush is stage 3. Esophageal candidiasis is stage 4. Well, how do you diagnose the difference? Well, the best way, and really the only way to diagnose it, is you take a camera and you look down the esophagus. Well, I'm not sure anywhere that actually, other than maybe Albert Lutuli, that can do that. So how do we diagnose it? Well, if they have oral thrush in their mouth, you do a quick exam, look inside, and they're also having symptoms in the esophagus. Well, the chances are it's also in the esophagus. So if they're feeling like a burning pain when they swallow, it feels like things get stuck when they swallow, okay, tightness in the chest when they're swallowing, and they have thrush in the mouth, well, that's esophageal candidiasis. That's stage 4, and they'll qualify for treatment. Okay. If it's very, very severe oral thrush, meaning it's everywhere in the mouth, like in this one where it's on the sides, it's on the top, it's on the tongue, it's everywhere, well, it's probably not just going to stop at the back of the throat. It's probably going to continue down too. Okay. So I might call somebody esophageal candidiasis when it's very, very severe. Call them stage 4, and we know that they'll qualify for treatment. Wasting syndrome. When you can see people's bones sticking out, see their vertebrae, see their scapula, you don't need to do a CD4 count. You know this person qualifies for treatment. Severe malnutrition, even worse than moderate. These are often the kids with the big swollen belly, big swollen legs, protein malnutrition. This is a severe condition, requires hospitalization. If you see another child here, this is the 2 different forms. This is a child with malnutrition, severe wasting. This one doesn't show up very well, but if you press on that, I pressed on his foot and you can see my fingerprint indented there. That's severe malnutrition. Okay. These children need to be started on ARVs quickly. They need nutritional support, and they need treatment quickly. This child here, from Don McKenzie, very, very, very malnourished. Way, way, way under the graph. His graph, he's an older child, he's 13 now. He was actually in the writing, where you start to write the name of the child. It wasn't even on the paper anymore. It was where he was for weight. I saw him yesterday. He's at 25% of his weight. He's been on treatment for 1 year now. He's completely normal weight. I wouldn't even recognize him as the same child here. He looks like a normal 13-year-old boy. So ARVs, they work, and they help tremendously in children with malnutrition. So we went through these. These are some of the things that are suggestive of HIV. If patients are presenting with these, particularly children, we need to be testing them for HIV. Doesn't mean they definitely have it, but it's very, very, very suggestive. Okay. Diagnosis we talked about today. Younger children, less than 18 months, DNA PCR, definitive diagnosis. Children older than 18 months, a simple rapid test can diagnose. So the take-home message, the bottom line is, if a patient is sick, they should be tested for HIV. We should, if they're sick and they test positive, we should start them on ARVs as soon as possible, based on both clinical criteria and immunologic criteria. Any questions?